Hi, good afternoon, everyone. And for those of you who don't know me, my name is Nadeem. I'm a GP and a cases ENT reviewer for the past 6 years with Primary Care Sheffield. I've been given the rather envious task of presenting the last presentation for the day. I'll try and be as brief as possible for as long as I can. We'll be doing a double act today. I've got Professor Jaideep Ray with me. Many of you will know that Jaideep is an ENT consultant. He's the clinical director for ENT, but you might not know that he's also the High Sheriff for Sheffield and South Yorkshire for this year, 23-24. He's also the Deputy Lord Lieutenant for South Yorkshire. So quite a few laurels on him, and he's kindly agreed to come and do the double act with me. So for the next 20 minutes or so, we'll try and talk about some of the urgent and emergency presentations that we get in primary care. Most of these are things we see on a regular basis, but sometimes it can be a bit difficult trying to understand or sometimes manage either as an emergency or as an urgent presentation. And for clarity, what I mean by emergency is those patients that you need to pick up the telephone and speak to the ENT on-call team the same day. And urgent presentations are those patients that perhaps can wait a few days, maybe a week, to see the ENT on-call team, either in their emergency clinic or perhaps in the outpatient department. So most of the ENT emergency presentations are foreign bodies, infections, and followed by any sort of cancers and so on. The urgent ENT presentations are sensory neural hearing loss, problems with otitis media with effusion in the ear. There's a bit of talk about what's otitis, malignant otitis externa, also called as skull-base osteomyelitis, and then moving on to a few more nasal and unilateral tonsils in the throat that we manage as urgent. Most of this is based on data that we've got through cases, because sometimes we do get referrals where we have to send back to you with advice to upgrade it to an urgent referral. So most common presentations that require you guys to pick up the telephone and speak to the ENT on call are going to be foreign bodies, either in the ear, nose, and throat. And foreign bodies in the ears are more commonly found in the junction between the cartilaginous and the bony part of the ears. And that's where you decide, is the foreign body an organic or is it an non-organic foreign body? So organic foreign bodies are those foreign bodies that can swell up as a result of water getting onto them and therefore cause further trauma to the external auditory canal, and there's a risk that that foreign body can perforate the drum. This can include at various times some vegetable pods like pea put into the ear. It can also be sometimes a cotton bud that can swell up within the ear. All of these need urgent same-day ENT review to prevent the risk of trauma and injury to the drum. Non-organic foreign bodies are more commonly seen, typically found nowadays through all of the beads and the gems that young children have. There is a theory on how that lands from the box into the ears, but that's for a different time and date. But these foreign bodies because they're not organic, they don't swell up. So you can potentially give a call to the ENT doctor, but say, can I book this patient into the ENT emergency clinic within the next week to have this removed? However, there is one non-organic foreign body, which is lithium batteries. This is an emergency. If you find that there's a possibility of a lithium battery anywhere in the ENT, either in the ears, nose, or the upper aerodigestive tract, that's an emergency. The risk of a lithium battery is the leakage of chemicals, which can cause necrosis of the mucosa as well as the skin lining inside the external auditory canal. So that's an emergency, and that needs an ENT review immediately. We all manage acute otitis media regularly on a daily basis, but sometimes patients can present with a swelling in the post-auricular space with fullness of that area and the ear pinna is pushed forward. That's acute mastoiditis, more commonly seen in children, particularly where the mastoid process is not well developed. These patients require admission to the hospital, not oral antibiotics, because they will require IV antibiotics. And sometimes they end up having a surgical drainage of that abscess, as well as cortical mastodectomy in the olden days. I'm not sure if that's presenting very well, but auricular hematoma is a swelling of the pinna, usually after a history of trauma. It's a tense, tender, fluctuant swelling that the patient will present to primary care, usually preceded by a history of trauma. But these patients can also have sometimes infections that can cause the swelling within the pinna, most commonly due to perichondritis or an abscess within the area. This needs prompt evacuation, so it needs an urgent, immediate referral to ENT. The risk is that if this is left for a couple of days or even longer, that starts to form a fibrosed area and then leads to cauliflower ear. That's medico-legally indefensible. So if you have a patient with an auricular hematoma or a suspected auricular hematoma, please ring up the ENT on call and refer this patient immediately through to them. Treatment-wise, is they would make an incision across the auricle, drain out the fluid, either pus or liquid, and then put in braiding stitches to try and prevent that from happening again. A simple drainage of auricular hematoma will just cause it to recur again. We all know what this is. Usually presents in primary care, usually presents to ED rather than to primary care. Bobby has put a small thing in the nostril. I'm not sure what it is. ED would remove it without any need for anesthesia. Now that's fairly easy to look at, and there's no point guessing the diagnosis. But more commonly, we might have a presentation like this, where mom has brought Bobby in with a unilateral foul-smelling discharge, and that's been going on for a few weeks. And if you were to look at it, you might then notice a foreign body inside. So if there is a child with a unilateral foul-smelling discharge ongoing for a few days, please look and see whether there's presence of foreign body. That's not rhinitis. That could be a foreign body in the nostril. All foreign bodies in the nostrils need emergency ENT review because the risk is that this can be aspirated, and therefore they need a same-day examination by the ENT team. And again, remember lithium batteries, they can cause significant necrosis. Complications from sinusitis. Now again, sinusitis, we treat them with antibiotics, fairly common. Just to be aware that there is a complication of sinusitis which can present to primary care, and that's periorbital cellulitis. It could either be preseptal, which means it's in front of the orbit and therefore it sort of connects to the upper eyelid, or it could be orbital cellulitis, as it is in the case with the CT scan, where you can see all the pus that's going on the right side of this maxillary sinus, moving up to the ethmoidal sinus and infecting the orbital area as well. These patients usually will have symptoms of eye pain. They might have proptosis, they'll have restriction of eye movements, and they'll have significant redness across both the upper and lower eyelids. The classical picture would be like that. More commonly, again, seen in children rather than adults because of poorly developed sinuses in children, and therefore all of the increased higher risk of getting infections behind the orbit. Again, these children do not need oral antibiotics. They need admission for IV antibiotics. They'll probably have a CT scan, and they might even have a surgical drainage of the abscess. The red flags always when you see such patients are, can they look at color vision? Because if they can't look at color vision, that shows them that there's significant orbital compression of the retina due to the abscess. They might have proptosis, and they'll have a restriction of eye movement. So any of these red signs are there. Pick up the phone, speak to the ENT on call, they need admission to it. Sometimes you might just get preseptal cellulitis, which is where the infection is only in the upper eyelid, and you could observe the patient for 24 hours, give them oral coamoxiclav, and then safety net with the patient to say, if this gets worse, if the redness increases, involves lower eyelid, if they have difficulty looking at color vision, I usually say if they can't see red or green color, then that's straight to A&E at the children's hospital or adults if it's an adult. I'm not going to talk about epistaxis. We all know how to manage that. There's also a very good video that we developed with Jaideep, and that's on the PCS Cases website, which actually shows how to manage epistaxis in primary care. But I just put this up just to highlight unilateral epistaxis in adolescent males. We've got about a few referrals that have come through for males between the age of 16 to 19 with a history of unilateral epistaxis. Can't find the source of bleeding in the littles area, but the epistaxis is quite profuse enough for them to happen 3 to 4 times a week. If you have that in an adolescent male, do think about nasopharyngeal angiofibroma. It's a rare tumor, it's a vascular tumor, it's a benign tumor, but it does cause significant bleeding in adolescent males. It's probably 99% only seen in males rather than females. So it's quite a unique tumor. You might be able to see a mass within the nasal cavity, but that's if it's a big nasopharyngeal angiofibroma. More likely, because it's nasopharyngeal, it will stay behind, it'll be in the nasopharynx, so it'll be difficult to see. So if you have a patient, adolescent male, with unilateral significant epistaxis, please refer them urgently to the ENT team. That's not a routine referral through cases. And again, just to look at septal hematomas as a cause of nasal obstruction following trauma. A patient will say, I had a history of trauma a week, not a week, probably 3-4 days before, but they come to you with nasal obstruction. It could be due to a deviated septum secondary to the trauma, but be aware of a septal hematoma. A septal hematoma will always present with boggy septal swelling bilaterally, bluish, pinkish color, and it will be very tender. That's an emergency, because the risk is if you don't send this to ENT, there will be septal cartilage necrosis leading to saddle deformity. And again, like the cauliflower ear, that's medico-legally indefensible. So the way I would do that is use a cotton bud or use one of our microbiology swabs to try and probe that. If it's a deviated septum, it's going to be quite hard or feel firm actually when you're probing it, whereas septal hematoma will be tender and it'll be fluctuant. If you're in doubt, it's always better to refer and get them seen by ENT rather than reassuring the patient and sending them home, because it's a catastrophic event if the patient has got a saddle deformity. And finally, just some on the throat, the most common emergency that you'll always refer is foreign bodies in the throat. Anything in the upper aerodigestive tract, which is in the back of the tongue, lower down in the tonsil, in the vallecula, or even into the upper aerodigestive tract, which is the pariform fossa. Foreign bodies there will usually be pointed out by the patient as saying one-sided. So they might either say, I've got it down here, if it's base of tongue or tonsil, or a bit lower down in the neck. If it's below the level of the upper esophagus, if it's middle or lower third esophagus, it'll usually be a midline foreign body sensation rather than up in the neck. Again, as always, these require emergency ENT review on the same day. And finally, just on emergency infections, peritonsillitis, patients present to you with significant amount of sore throat, history of fever. Interestingly, they might present with trismus as well, and that's because of inflammation of the periorbital muscles out there. And when you look into the throat, you find this big boggy swelling across the peritonsillar area. These need IV antibiotics. Sometimes they require the steroids to reduce the inflammation, and they might stay in for a while. The guidelines have changed, so I think if you have a patient with quinsy, which is present over there, and he's had it twice, this patient needs a tonsillectomy, because what's happened with post-healing process, there's a lot of fibrosis across the peritonsillar area. So once you've had quinsy, your risk of having quinsy again increases, so these patients need to be referred for tonsillectomy. And this is not projecting very well, but this is acute epiglottitis, thankfully a rare condition now, but we used to get them previously where usually a child coming in, drooling saliva, having difficulty breathing, and just not moving. That's an emergency. I mean, that's an ambulance 999 emergency to ENT, because these patients need urgent review. You would get the anesthetist involved because they can crash their airways suddenly, but the mainstay of treatment is IV steroids, antibiotics, and monitor the child quite closely in ICU or HDU. That's me for emergency. We'll have Jaydeep now just doing the urgent presentations. I'm happy to take questions at the end. Thank you.
Right, two quick disclosures. Nadeem and I had done this joint act a few years ago, probably pre-COVID, and he just said, I'll put the slides together and you can come and sing for your supper. And the second thing is I'm really overdressed for an NHS meeting. Then when I came in, I'd been to a civic meeting, but then I was just sat here thinking, this is how SHOs used to come to work when we were kids. So how the world's changed. Two quick warnings. That septal hematoma, when you're going to probe it with the microbiology swab, stand to the side of the patient because you'll get a massive kick if it's thingamabobs. The foreign body esophagus, I'll just narrate a very quick story to you. When I was a registrar, and in those days, safeguarding wasn't a big issue. It didn't kick in. This child became dysphagic, septic, and toxic. And the child had a retropharyngeal abscess. And when the child had just a simple X-ray, it had been going around the floor in broken glass, eating glass. So be careful of trapped foreign bodies. So send them for imaging quite early. And simple X-rays will pick it up as well. And nowadays, a lot of other things will kick in very quickly. So you get these patients more often than us, or A&E, sometimes on neurology, acute vestibular episodes. They come dizzy. Sometimes ambulances pick them up thinking there's a stroke or something like that to exclude any other neurology. Two bog standard diagnoses. Labyrinthitis is basically a dustbin diagnosis for any patients with acute dizziness. And it still works. They come to the hospital, some pompous ENT consultant will say, oh, labyrinthitis doesn't exist. This, that, and the other. So I thought I'll just show you the two different aspects of this. Basically, if you do not have hearing loss, but you have acute episode of dizziness or rotatory vertigo, nausea, vomiting, and the patient's incapacitated, it's likely to be vestibular neuritis. It's just semantics. But even if you called it labyrinthitis, it isn't a problem. The trouble with labyrinthitis is the patient will lose hearing and it can have a catastrophic hearing loss. They walk around like a crab. They need somebody to hold them. They can't go to the toilet. They'll have to crawl to the toilet. One episode, acute labyrinthitis or vestibular neuritis, depending on hearing loss. Multiple repeated episodes, you're starting to think of Meniere's disease, etc. So another time you get a criticism back from some of the consultants is, oh, the patient had Meniere's disease and the GP referred it to as labyrinthitis, and then the patient gets riled up and they come back to you and say, oh, you didn't diagnose it. In a litigious climate, just remembering the difference is important. It can last for up to 3 to 4 days. But basic treatment options are supportive care. When they're going through an acute phase, they'll be throwing up, etc., etc. So you would want to rehydrate them and suppress the acute symptoms, which will be anti-emesis and vertigo suppression. Cyclizine works very well, Bucostem and the like will work, or you can give them an injection. Subsequently, they will become a vestibular cripple for a few weeks to months. It takes ages to recover fully, so don't lose heart. And giving that support to the patient and being confident in stating that to the patient is more crucial than anything else. So you'll take 2-3 months to be fully functional. So being up and about, mobile and exercising is crucial for them. If labyrinthine symptoms are associated with potential meningism-like symptoms, you're thinking seriously of meningitis, and they really need a very immediate referral, particularly in children. Firstly, because they're likely to be having a meningitic episode. 2, if they're left for long, the hearing will die, and they will struggle to get a rehabilitation with the cochlear implantation. What happens is they get new bone formation within the cochlea, and the implantation doesn't work as well because the cochlear implant can't be inserted. So very, very early referral for this is important. This is another area that has become quite sensitive because oftentimes patients with balance issues, acute vestibular episodes with other neurology are likely to have a posterior fossa stroke in the very near future. So checking on their cardiovascular status, etc., which you guys do very well, is very important rather than just treating the vestibular aspects like we do. Okay. And the clue is when they have other neurology. Generally, for a labyrinthine episode, you're not going to have numbness, facial numbness, visual disturbance, etc. So the symptoms are purely otogenic, so rotatory vertigo, nausea, vomiting, and hearing with or without hearing loss. But any additional features, you're really worried about pending catastrophic neurology. Facial palsy, again very common, reaches primary care and A&E more often than us, and quite rightly. Majority of them are Bell's palsy, which is idiopathic. If they have a recrudescence of their herpes virus infection, they would get blisters and vesicles in one of the external canals and the conchal bowl, excruciatingly painful. They need supportive care, and early steroids is usually most beneficial. Majority will recover over a period of time, but some of them would benefit from, or all of them in fact would benefit from early steroid. Sometimes can follow a viral prodrome, sometimes may not. And again, with a sudden patient waking up with a sudden facial palsy, paramedics generally bring them either to you or to A&E straight away. If, however, your patient has come back after 2-3 months of the initial episode with no recovery, I would not sit on that. I would definitely refer them on to secondary care, particularly for imaging purposes. The chances of it being an unrecovered Bell's palsy are in the region of 20%, but there is also a chance that there was pathology which hasn't been picked up, and the best way would be an MRI scan. If you have access to scanning, MRI, IAMs, and the parotid would be what you would require to do. Eye care is another one. Best is to tape the eye. If you keep an eye shield and the eye is open inside, they will develop corneal ulceration. So even sellotape, if the patient has nothing for the first night, taping the eye down, and then also facial massage, rotating facial massage, and also patient exercising the facial nerve, forehead down to the neck. So it's very simple. Just ask them to exercise using the same tests as you do for a facial nerve test. So raise the eyebrows, close the eyelids shut, blow the cheeks out, smile, and show the neck muscles. Other sensorineural hearing loss is yet another one, which you get, and often a qualitative history is good enough. If they wake up with a sudden hearing loss, and even if you suspect malingering or whatever, the chances of it recovering with early steroid is better than without. So 60 milligrams of prednisolone, 40 to 60, unless there are any contraindications for 5 days, is absolutely fine. Once daily, as was mentioned. Some people end up, hospital juniors particularly end up giving BD dose, etc. It's not necessary at all. There was debate about acyclovir, but there is no evidence that any antivirals work, but some people still use it. There is no evidence whatsoever. Again, exactly same as Bell's, persisting beyond 2 to 3 months, either MRI, the IAM yourselves, or send it to secondary care. Unilateral medullary effusion, you see that once in a while, bubbles behind the eardrum and with a hearing loss, which is of a conductive nature. If it's following a flight or a cold, etc., you can sit on it a little bit, give them nasal decongestants, ask them to do a Valsalva's maneuver to pop the ears, and give them 2-3 weeks. But if it's persisting in an adult, you want to exclude postnasal carcinoma or nasopharyngeal carcinoma. And it is one of the most prevalent carcinomas in patients of Southeast Asian origin, even if they have migrated to the country. EB virus is one of the odd ones. So here's a piece of useless knowledge for you. EB virus causes Burkitt's lymphoma in Africa, infectious mononucleosis here, and nasopharyngeal carcinoma in the Far East. And that's used as a monitoring titer. after treatment. And I have seen in our tertiary practice a few fairly well-placed colleagues within the hospital who have had a late diagnosis, mainly through their own negligence in that they haven't bothered, oh, I'll get better, self-treatment, etc. So low threshold for referral for this, definitely. And no, if it's just a medullary effusion, recovers, nobody's upset about that referral at all, but it's well worth it. This guy, recurrent ear infections, diabetic, slightly frail, face drops. Any ideas, any diagnosis, any volunteers? Yeah, malignant otitis externa or necrotizing otitis externa is a common problem now, and particularly with Pseudomonas, which has become fairly ciprofloxacin resistant. When I was a boy in the last century, we used to just give oral ciprofloxacin for 3 months. That doesn't work these days. Patients have to be brought back for regular cleaning, oral toilet, and topical antiseptics, and many of them end up on our OPAT system for tazocin, etc. Very highly expensive, and the mortality, not just morbidity, the mortality is significant. You're looking at 10 to 15% mortality in this day and age of advanced treatment regimes. So very low threshold for referral with this. Nasal bone fracture, don't sit on it. Either hit the patient and see if you can straighten it, or ask a friend to do it for them, whoever's dislodged it. Friday afternoons particularly, are it's endemic on Friday afternoons. If it's the nose, it's fine. If they have associated nasal injuries, or if they've come a bit worse off trying to fight the supertramp, then it's absolutely major trauma. But if it's a straightforward nasal injury, if it's fixed within 7 days, they can avoid a rhinoplasty, etc. Beyond 7 days, that'll get sticky, it'll set in, and that'll have to be refractured, and a proper rhinoplasty has to be undertaken. And the rationing or rationalization for that is quite strict, and getting access to a rhinoplasty in South Yorkshire is no longer as easy as it used to be. I used to do 10 per year now myself, so we shrunk that practice to 1 consultant, and that too he hardly does more than 3. A lot of patients are sitting around with that. So if you can avoid that, early dose is best. That take, inject, and give them a midazolam and bash it back in place. That's a medical term. CSF final 2, isn't it? CSF rhinorrhea, unilateral clear nasal discharge, like a tap. Like if I was having CSF rhinorrhea, if I sat here, it'll be drip, 1 slide, drip, 2 slides, drip, drip, 3 slides, drip, drip, drip. And it's just clear like rainwater, which can be collected. You can get the patient to collect it. If they strain with their head between the 2 knees and strain, they will get a bit more sample. You can send it for beta-2 transferrin. It's clear. If it's positive, then it's definitely CSF rhinorrhea. You can get it in nasal allergy, but that's to differentiate that from the unilateral foreign body in children, which is more infected mucoid. This is clear, crystal clear water doing drip, drip, and they can demonstrate it regularly. One old traditional test was if you put a filter paper or standard tissue paper would do as well. It's just clean, stretch it. If you put 1 drop of that on it, it should have a halo. And it used to be called the halo test when beta-2 transferrin was a very expensive one. But I wouldn't rely on that when you get a test. So can be traumatic, can be idiopathic as well. And they can get meningitis if left untreated. So the key is referral, and that can be sealed off. So tonsillar enlargement is potentially carcinoma, lymphoma, or storage diseases. And they're very different from tonsillitis, very different from peritonsillar abscess, because they're not inflamed, they're smooth, rounded. If it's carcinoma, it's very craggy. This lymphoma is smooth, carcinoma is very craggy, and then you look at what the symptoms will be, dysphagia, pain, etc. Right, that's us done. Any questions? Thank you.